Hello, everybody. My name is Edward O'Connor from Transaid. It's great to see everybody who's been able to join. I've seen many familiar faces from different parts of the globe who've joined. Aggie from FIA Foundation, nice to see you here. We have Florence from Transaid, nice to see you. Jeff Turner, it's good to see you on the call as well today on the webinar. Sarah Nankolis, it's lovely to see you on here as well. So it's good to see a really good mixture. Tendai as well from Development Data. I assume you're in Zimbabwe, which is great to have you on board as well. So it's great to see so many people who've joined today. So today's webinar is going to be about stepping up the fight against malaria and COVID-19 in Zambia, a community-based severe malaria intervention. So for today, we have several speakers. So it's myself who will start off, and then we have some of the programs team, Ruth Nyirenda, we have Ernest Chanda, we have Dennis Simunya, we have Auxilia Puringonda, we have Caroline Barber, who will join us for the Q&A session. We have Kathy Green, Paula Quigley, Dr. Chapa from the District Health Director of Serenge, and Dr. Mudenda, who is the Acting Director of the National Malaria Elimination Center in Zambia. So before I start, I'd just like to say that we are very grateful to all the partners who have supported MAM Scale and predecessor projects in Zambia. So this includes Grand Challenges Canada, Medicines for Malaria Venture, FIA Foundation, Comic Relief, and Transport and Logistics Sector partners in the UK. So as a brief outline for today's webinar, we will be doing scene setting, MAM Scale approach, integration of COVID-19 response, results, scaling up activities and plans, the questions and answers, final comments, and closeout. Now, we are also very fortunate today to have two guest speakers. They are Dr. Ben Rolfe, who is the author of Leave No Fever On, and also we have Hans Rietveld from Medicines for Malaria Venture. So without further ado, I'd like to hand over to our first guest speaker. Please, Ben, the floor is yours.
Thanks, Edward. Thanks. So I'm just going to make a few brief remarks. For those that don't know me, my name is Dr. Ben Rolfe. I've been working for 25 years on health systems, health financing, health diplomacy, including maternal health, sexual health, but also malaria. And I was lucky enough to connect with colleagues from Transaid as I was producing the report that Edward mentioned, No Fevers Left Unresolved by Malaria No More and UN Foundation. And that took the work of MAM Scale as an exemplar of excellence. More broadly, I just wanted to make some comments about the COVID crisis, which has given the world a devastating lesson in what it's like to live with health insecurity. And whilst vaccines have historically provided protection to those in the global north, many in the global south have long been living with the same health insecurity that would have been familiar to perhaps my great-grandparents, but not to those living in Europe, North America, Singapore, Australia until now. And COVID has shown us all the reality of living with health insecurity, and of course should galvanize the world to act. And of all the threats facing the global south, malaria is of course the oldest and most deadly. We've seen 229 million cases and 400,000 deaths in 2019, and COVID has further undermined our ability to respond to malaria. And malaria is a disease that really thrives in places with weak health systems. As we've seen in Asia, where we invest in those systems, we see a rapid decline in malaria. And globally, 7.6 million deaths, 1.5 million cases have been averted in 20 years of sustained global effort. And malaria is a disease that can be treated for $1, it can be tested for $1 and prevented with a bed net costing just a couple of dollars. So it is in a sense a great indicator of gaps in health coverage. A health system that can't deliver those basic interventions cannot protect their communities or indeed the world from outbreaks of infectious disease. So COVID must show the world that a village or a district or a country that cannot or will not afford these basic interventions put both their populations at risk and the world at risk. So investing in these simple interventions, community health workers providing information, testing, treatment are incredibly cost-effective interventions that protect local health and protect global health. But we're still seeing 2 million children under 5 die of malaria, pneumonia, diarrhea annually, and 40% of fevers in children go undiagnosed. So hopefully, if there's any positive coming out of the COVID crisis, it will be a renewed understanding that investments in investing in community health are not charity, but critical investments that underpin global collective well-being, productivity, and indeed the survival of our species, as the COVID crisis and previous pandemics have shown. Now, I was lucky enough to participate in the Lancet Commission on Malaria Eradication over recent years, and we estimate that at least $2 billion will be required to bring the world on track to eradicate malaria globally. And I firmly believe that stopping pandemics requires us to invest in these same systems that will also end the great endemic diseases like malaria, TB, HIV, and polio. And the work that many colleagues on this session are involved in provides extremely timely proof of the effectiveness of these simple, cost-effective interventions. And the program, Edward, that you outlined seems incredibly relevant and timely given where we are in both the modern health security crisis of COVID-19 and this ongoing health security crisis of diseases like malaria that are surely completely interlinked, as we will hear more. So with those short opening thoughts, let me pass on to Hans.
Thank you, Rolfe, for that great introduction. So I'm pleased to be here. Thanks, organizers, for the opportunity to be part of this important webinar. And I will share a few thoughts on the role of artesunate rectal capsules in the pre-referral management of malaria, of severe malaria. Next slide. So for patients in remote communities where comprehensive medical care is not immediately available, a pre-referral intervention with artesunate rectal capsules is indicated when severe malaria is diagnosed or suspected. And this single dose of rectal artesunate will benefit the patient during the time it takes to travel to a referral health facility where parenteral treatments with injectable artesunate can be provided for at least 24 hours and until the patient can take oral treatment. And then the third step in the continuum of care is a 3-day course with an artemisinin-based combination therapy, an ACT. Next slide. So the WHO Treatment Guideline stipulates that when intramuscular artesunate is not available, then children under 6 years of age shall be treated with a single rectal dose of artesunate, that is 1 or 2 100 milligram capsules depending on body weight, followed by immediate referral to a higher level health facility for parenteral treatment with injectable artesunate. And last week, the WHO issued updated guidance related to the storage in climate zones where the ambient temperature is usually above 30 degrees. And so procurers and distributors need to ensure that the product is distributed to community health workers located in such areas only as a short-term stock, generally not exceeding 6 months. And this is a welcome relaxation of the guidance, which previously was tighter. Next slide. So between the two WHO pre-qualified products from Strides and Cipla, these are now registered in 20 countries, and more country registrations are expected to come through. And finally, the use of artesunate rectal capsules is supported by a training toolkit developed by MMV, which is available for countries at severemalaria.org. In conclusion, last slide, I'm very pleased that the training on the pre-referral management of patients with severe malaria is now part of the ICCM training curriculum in Zambia, thanks to the years-long of good collaboration of the MAM Scale consortium partners with the Ministry of Health. With that, I thank you, and over to Ruth.
Thank you very much, Hans, for that presentation. I'm now going to take you through the program's overview as well as the approach. The severe malaria innovation is targeted at children aged 2 months to 6 years. And the innovation started in 2018, and in June to November 2020, it was extended to integrate the COVID-19 response. And then there's a new phase which started in December 2020, and we go up to November 2021. We are currently working in 10 districts, and our partnerships are National Malaria Health Eradication Center, National Malaria Eradication Center, and all the district health management teams in the 10 districts. Next slide. Most rural communities in Zambia encounter many delays in accessing treatment for severe malaria in children. As a result, we have many unavoidable deaths that have occurred. And according to the World Health Organization 2020 report, we've seen that an estimated 7,882 malaria deaths occurred in Zambia, which is really a very high figure for our communities. Next slide. There are various barriers and delays that affect communities, and some of them are low awareness on severe malaria danger sign. Very few people would easily recognize that the child they are having or the sickness that the child is facing is a sign of severe malaria. As a result, they might cause delays, or this might be a barrier to some parents that might not easily access the facility. There's also lack of emergency transport options. As you may be aware, some communities live in far-flung areas where transport is not an option, but it's something that one has to think about as how they'll get this child to the facility. There are also challenging terrain. We have streams, we have rivers, and at times they get flooded. So it's presenting a challenge for a parent or a carer to take this child to the facility. There's also lack of affordability for certain essential things that a household might need. There's also lack of food for carers and patients when at health facility. As you may be aware, when a child is given rectal artesunate, they have to be admitted. But because of lack of food, some it tends to be a barrier, and actually for some it can be a delay as they try to look for food to take to these health facilities. Next slide. We'll now look at the approach that we are using. This innovative training of the CHV is at the heart of the MAM Scale team, where we are training low literacy clients or communities in such a way that they are able to even mobilize their community. And at times, we even use communication tools or things that are easily understood and adapted in the community. We have a rapid imitation method where one would say something and then everyone imitates. And there's also the sing and do, where we use songs where communities can sing and understand the key messages that are there. We also use communication body tools and actions where even small children are able to relate to these. This approach has also enabled to train RAS administrators in various communities around the country. Also, the approach has involved the formulation of community systems, and some of these are the community transport system, where in short we call it the bicycle ambulance. We've placed this strategically in various communities or around the facility where everyone who faces a transport challenge can access them. There's also the establishment of food banks, emergency saving schemes, where communities come together, put up monies, put up food, so that anyone who faces a challenge in going to the facility, they are assisted by this same scheme. And also, there's a collection of data. This is done by the community health volunteers as well as the riders. Next slide, please. That is showing you some of the communication body tools that relay key messages and actions. The top one there shows the CHVs and community members demonstrating vomiting. This is a sign of severe malaria, and it can be demonstrated where everyone gets the message that it stands for, as well as the folding arms there and putting them on the chest. So it's the sign of fever. And these are easily taught and repeated so that they can be remembered. And these tools also are suited to a low literacy context. Next slide. The approach also involves the training of health workers in severe malaria case management, also including the injectable artesunate. When a facility staff is trained in how to administer injectable artesunate, it does not end on this person alone, but it cascades the training to other facility staff, so that even if a child may come from the community, he or she will be attended to on time because everyone is trained. There is also the strengthening of linkages between facilities and communities. During the training of community health workers and riders, community health facilities are very much part of this training. As a result, they're able to even provide supportive supervision for volunteers. The approach has also influenced national scale-up, where the model that we use in the demonstration districts of Serenja and Chitambo has been scaled up to other districts where they're also following the model of the approach. And this also has enabled us to have a lot of advocacy and also dissemination. The approach also has enabled us to build capacity in the districts where we are working in, where we do not only focus on just a district. We have focal persons that we work with. We have the malaria elimination officers, as well as the emergency transport system support persons. These are placed in districts where we have emergency transport system or the bicycle ambulance. And also the districts themselves are able to monitor the drugs and commodities around their facilities. I'm now going to hand over to Ernest, who's going to carry us through the next presentation.
Just an advice to the listeners. I'm sure questions will be around at the end of maybe the presentations. So if there are those that have been writing questions, I'm sure there will be a session for questions. So just to continue from where my colleague left, we integrated the component of COVID-19, and under this component, the project looked at supporting Ministry of Health to develop national COVID-19 community engagement guidelines. And we also looked at planning with the DHMTs because we needed to agree on how we are going to intervene. As you are aware, COVID had come at a time that we still had malaria. So this had come as another burden. So we needed to plan with the DHMTs on how we are going to intervene. And we also looked at how we are going to engage traditional leaders who are some of the strategic partners on the ground. And we also looked at producing the posters. You are aware that COVID had come with a lot of information. Different organizations had printed posters. Also, Mamas Against Malaria did print some posters, which were produced both in vernacular and English as well. And we also looked at doing a number of radio sessions, which also attracted senior district government officials like DCs, district commissioners, as well as district administration officers, and also the epidemic preparedness team from the council, as well as from the district health office. We had quite a good number of sources of information from reliable and trusted sources. Next slide. And under prevention and response in community, the project looked at developing protocols for the CHVs, or the community health volunteers, and the riders. The riders who are the guys transporting patients to the health facilities. We looked at giving them safety protocols because they were operating during the time of the pandemic, and almost each and every patient, they were advised to treat each and every case as a suspect for COVID. So protocols were given to them, and in picture there, it's an example of an ETS rider protocol, which was given to the ETS riders. Also, volunteers that are administering RAS, they are also given a similar kind of a protocol, which is not in the picture here, but it can be found in the information. I think that will be available to the team after the presentations. During COVID-19, as a project working together with the GHMTs, we managed to sensitize the communities, beginning with trainings or orienting community health volunteers in COVID-19, as well as community riders, and also worked together with the frontline health officers in disseminating COVID-19 information in prevention and response. We managed to sensitize the communities using different strategies. We used peer system, sensitizing the communities using peer systems, going almost to each and every community, and also the use of posters, sticking posters around the communities, as well as focus group discussions in the communities. We managed to sensitize and reach out to almost every door. We supported community food banks, which was, these are community systems that are meant to support both maternal and malaria emergencies. But during COVID-19, as a project, we looked at emergency safety nets. So food top-ups were given to supplement on already existing food banks. So these were meant to support families that were going to be affected by COVID-19. And also in promotion of hygiene, as a project, we managed to work with the communities in constructing hand washing stations, which was the tip-tap innovation. Almost each and every household, they managed to construct a tip-tap innovation, which is in the picture there. And another aspect which we looked at was gender-based violence. Next slide. Gender-based violence was on the increase during the pandemic, and as you may be aware, COVID had actually come with a lot of negative impacts. People had lost jobs. There was an increase in the cost of living, and that amounted to a lot of pressure to the women, more especially the girls. And as a project, we looked at that component and responded positively by working with the volunteers in promoting zero tolerance for gender-based violence. We had radio sessions where we invited community health volunteers, as well as the DHMT. We worked together with the DHMT through the Office of the Adolescent Officer, and we had live phone-in sessions where people could ask questions and answers were given. And this gave a good platform for people, and which they needed at that particular time, because COVID had come at a time that people were still struggling already with some of the existing issues. So the coming of the program for COVID activities on radio programs came as a prayer answered to most of the people around Selenge and Tambo, and we actually managed to reach out to about 90,000 listeners between Chitambo and Selenge. So my colleague Dennis is going to take you through the results. Next slide.
Thank you so much, Ernest. My presentation will focus on the results of the various interventions that we undertook as a project. So to start with, I just want to inform you that we had a robust baseline survey which was conducted in February 2019, and the midline survey which was conducted in July 2020. Apart from this, also we conducted the two RAS verification exercise, and the last one being in December 2020. It may be important to mention to you at this point that we have a system which we are using to collect data from the communities. This data is collected on a monthly basis by community health volunteers, which is shared with the program team for analysis, and our results are based purely on this data. Next slide, please. That slide there is a snapshot of various results that we managed to obtain from our survey. I'll go through some of these. And to start with, we surpassed our population coverage. Our target was 115,000, but we actually managed to reach out to 320,000. Yeah. So the other indicator that we were looking at was the changes in knowledge and confidence. For example, I would just pick some of them. Female volunteers' knowledge of severe malaria danger signs. At baseline, we were at 72, and at end line, we were at 99. Midline, we were at 99. Case management, I can pick an example also. Community volunteers who managed cases of severe malaria, at baseline, we were at 79. At midline, we were at 93. Under gender empowerment, 98% of female CHVs felt that they had a stronger voice in their community, which is a very, very significant, figure. During the midline, at midline point, 3,216 children received a rectal artesunate. I just want to mention here that this figure is slightly lower than what we had anticipated or our target. And the reason was because the proportion of simple malaria that was progressing into severe malaria reduced. At baseline, we were at 2.2, and at midline, 1.1. And the reason for all this was because due to the various interventions that we put up in the communities, community health volunteers and families of the sick were able to, handle these simple cases of malaria before they could, progress into severe malaria. Next slide, please. I also just want to mention that based on this, we estimated that we saved about 193 lives based on our survey. So next, I'll dive into the COVID-19 results. And my colleague has already spoken about some of the issues that I'll speak here. Our project took advantage of our already existing strong community systems that were in place to be able to respond and incorporate the COVID-19 response. Some of these activities that we, adapted to be able to respond to COVID-19 was the food bank. My colleague already spoke about the food banks. We talked up about 180 food banks, which were already existing. And the idea here was to strengthen the community resilience during this time. We also adapted our already existing community-based transport system to be able to respond also to COVID-19. We oriented 1,673 community health volunteers on COVID-19 prevention and so on and so forth. We also oriented, or rather, we also gave some training to our riders on COVID protocols to make sure that they are able to deliver these patients of COVID safely. Apart from that, we were also engaged in public awareness, public health education. So we undertook program, radio programs. We also distributed posters. We also, did up to 20,000 door-to-door visits, just to raise COVID awareness among the communities where we are working. We also procured personal protective equipment and distributed across various intervention sites, that is to our volunteers and also to frontline staff in the areas where we are working. One of the greatest achievements that we have achieved and that we are proud of as a project is that Our experience was integrated into the national COVID guidelines for community health workers and also into the UNICEF and WHO COVID-19 community engagement guidelines. All of this happened over the period of April to October 2020. Next slide, please. Here is a slide that gives us just the results of what we achieved under COVID. For example, at midline in July 2020, more than 80% of our volunteers, our community health volunteers, knew the three major danger signs of COVID-19. 79% of community volunteers reported that GBV had disappeared or reduced a lot in the recent years. So, and only about 1% of the community volunteers indicated that they lacked normal training in COVID-19. So basically, we were able to achieve these results based on their different interventions that we did. I'll now focus on the graph that is tabulated below there, and I'll just go through a few. And this was focusing basically on to see whether our volunteers knew the signs and symptoms and preventive actions, on COVID-19. So, for example, 89% of our volunteers knew that a new continuous cough was a sign and symptom of COVID-19. Similarly, 85% of our volunteers knew that difficulty in breathing was a sign and symptom of COVID-19. Similarly, on the other side, preventive side, 96% of our volunteers knew that frequent washing of hands with soap and water was a preventive measure against COVID-19. 83% knew that keeping a distance of 2 meters was a preventive measure against COVID-19. Next slide, please. Our survey also focused on the drug situation in various intervention sites. So basically, the drug supply, improved in the 2 demonstration districts, that is Chitambo and Serenge. Health facilities with 5 key malaria drugs increased from at baseline 35% to 73% at midline. The availability of RAS improved in the demonstration district. 11% of the health facilities had RAS at baseline compared to 81% at midline. And the reason was because the government started to procure RAS. That's why you can see that significant difference there, improvement rather. In all the 5 intervention districts, that is the demonstration district and national scale-up district, the availability of injectable artesunate fell. Only 48% of the intervention health facility has this drug at the time of the midline survey, compared to 88% at baseline. So similarly, this was a problem that came about because of the disruption that COVID-19 brought in the picture. So the drug situation in 3 new intervention district, that is our first new intervention district, national scale-up intervention district, Vugwi, Maninga, and Chama, was not as positive as the 2 demonstration districts. Overall, this affected our performance when we aggregated across the, across all our intervention sites. Next slide, please. That graph there is the snapshot of the position, or rather the status of the drug supply situation in our demonstration districts. I'll just pick a few there, and this only focused on the 5 major commodities of malaria. That is Quatem, injectable artesunate, Fancida, quinine, and rectal artesunate. So at baseline, injectable artesunate were at 82%. And at midline, we are only at 50%. You can see the drop there. And the reason, like I mentioned earlier on, was that, part of it was attributed to the disruption of COVID. Rectal artesunate were at 11% at baseline, and at endline, we were at 80% for the reasons that I've already said. So the aggregate picture in the demonstration district. That is health facilities with at least 80% of the required drugs, 35% at baseline, and at midline, 73%. Next slide, please. The next slide is a picture across all our intervention districts. That is the five intervention districts. Similarly, you can see the injectable artesunate, consistent with the previous slide. Rectal artesunate also consistent with the previous slide. I'll focus on the aggregate. At least that is the health facilities with at least 80% of the medicines available. At baseline, we were at 35%, and at midline, we were at 41%. Next slide, please. I spoke about earlier about the RAS verification exercise. And this exercise, just to give you a brief explanation of what we intended to achieve here is, this exercise was checking whether our community health volunteers gave RAS correctly and that patients received full treatment at the health facility. This exercise was carried out in December 2020, and we got a sample size of 100 cases, which we reviewed in the demonstration districts. The picture you are seeing there, the graph you are seeing there, only focuses on 10 of the 100 cases that we are focusing on. So the data that we are collecting here was the age of the patient, the sex of the patient, the date of arrival of the patient at the health facility, whether RAS was given at community level, whether an RDT was positive or negative, where the RDT was done, what were the danger signs that was observed by the community volunteers. What time did it take for the child from the time of administration of rectal artesunate to the time when they reached the health facility, whether the child was treated for severe malaria at the health facility, and what drug was administered to a child after receiving rectal artesunate, and what was the reason in case the drug was not given, what was the reason for not administering a severe malaria drug at the health facility, and whether the child survived. So based on all this, we came up with conclusions about this exercise. Next slide, please. We concluded, therefore, from this verification exercise that 95% of RAS recipients had their severe malaria diagnosis confirmed at health facility. This showed that our volunteers were closely following the severe malaria protocol. 37% of RAS recipients with confirmed severe malaria did not receive injectable artesunate due to stockouts of the drug. A similar exercise in October 2019 found that 10% of RAS recipients did not receive injectable artesunate at facility level. So you can see that COVID-19 brought in a disruption such that by the time we were doing our second exercise, verification of RAS verification exercise, we had these gaps of stocks of drugs due to disruption that were caused by COVID-19. Next slide, please. I will now talk about the challenges that we faced as a project in our implementation, during our implementation. Like I said earlier on, we had stockouts of injectable artesunate. We also had, problems with availability of SCTs for community health volunteers at community level. We also faced a poor gender balance among the, community health volunteers that were trained. So we also had lessons, we learned lessons from our interventions, and some of the lessons are that the community engagement and mobilization component is as important as the case management part. So if we pay too much attention on the community mobilization, we are able to achieve very, very good results. Gender smart strategies are critical to positive results. And also, we also concluded, we learned that well-trained community health volunteers working with a strong community health system can integrate new issues. For example, we were able to respond to COVID-19 using our already existing severe malaria structures. For example, we were able to, adapt our emergency transport system to, to respond to COVID, and also our food banks. So based on this, I will leave here and pass on to my colleague Auxilia. Thank you for listening.
Good afternoon, everyone. Thank you, Dennis. The pilot project, Mamas, which was then named Mamas Against Malaria, started in Serenge in 2017. On the map, it's shown in blue. In the first phase of MAM Scale, the project worked in 5 districts, including Serenge, plus the other districts which are highlighted in red. In the second phase of MAM Scale, the project has so far expanded to 10 districts, the new districts which are shown in yellow. In the second phase, MAM Scale is now covering a population of just under 900,000. Next slide, please. The national ICCM program is well funded. Integrating RAS into this program will help to sustain the innovation. RAS has been integrated into the national ICCM training program. The Ministry of Health is procuring RAS. In 2017, MAM brought the first RAS to Zambia. The fact is that now it is being procured by the Ministry of Health, which is really a positive stride for us. There are many RAS-trained community health volunteers in 10 districts. However, many other districts have ICCM-trained community health volunteers who have been given proper RAS or community mobilization training, and there's still a lot of work which needs to be done. A total of 439 health volunteers, health workers trained in severe malaria case management. 4 districts have been supported with emergency transport systems. As RAS is continuously rolled out, it will be important to provide refresher training in injectable artesunate to frontline health workers. There are currently 12 RAS trainers in Zambia. A future challenge is to rapidly expand the pool of RAS trainers. The large pool of ICCM trainers is the main target. Thank you. Over to my colleague, Kathy.
Thank you very much indeed, Auxilia, and thank you very much indeed to all the presenters and speakers this afternoon. It's been a very, very interesting session. We've now got about 7 or 8 minutes for a question and answer session. So do feel very free to use the chat function on your GoWebinar control panel to type in your question, and we'll do our very best to answer those in the time available. If we get into a position where we can't answer them all, we'll certainly have a go at answering them after the webinar. So I already have a couple of questions, so if I could get going with those. So the first question, and this is actually for Ben, what have been the key lessons in ensuring that we can continue to adequately address severe malaria and COVID-19 as well? What are the key messages to policymakers? So that's to Ben, please.
Thanks. Yeah, well, it's a good question. I mean, I think I'm hoping that it will become screamingly obvious to everybody how incredibly interlinked our global efforts for pandemic preparedness and the impact of pandemics are with the need to invest in this basic community infrastructure. You know, we have the technology and the tools, and increasingly effective tools thanks to work of people like MMV. The challenge now is to improve access to those tools. And I think, you know, there's a kind of bottom line issue that generally health systems in the global south are chronically underfunded and have been for decades. I'm hoping that this can, the pandemic can kind of catalyze some global effort and solidarity, and understand that investing in these very effective and proven technologies that are getting better every year, that investing in them is investing in a global public good. And so, you know, critical to that are the efforts of people like those on this call to demonstrate the effectiveness of these simple and cost-effective technologies, put them in front of policymakers and make the case, just as my colleagues on this webinar have done, for the importance, the simple effectiveness of these tools and the importance to finance them, because exactly the same surveillance systems, community health workers that we need to tackle diseases like malaria are, as we've seen from the presentations here, exactly those systems that you need in an emergency like COVID-19. So I feel somewhat heartened by the presentations we've seen today.
Great, thank you very much indeed, Ben. Excellent. We've had a comment about the difference between ARC, which is ARC, and RAS, RAS. Just to say that they are the same thing. The terms have been used interchangeably today. ARC stands for artesunate rectal capsules, and RAS is rectal artesunate. So they're the same thing, and RAS is the term that's commonly used in Zambia. So we use that one quite a lot. Okay, so the next question we've had is, were the bicycle ambulances that we've heard about today primarily used to refer malaria cases, or are they also used for other types of emergency, for example, COVID cases or maternal cases? And if they are being used for other types of cases, what impact are they having there? And I'd like to throw that one to Caroline, if possible.
Of course, thank you ever so much, Kathy. It's another really good question coming. The vast majority of the cases we've recorded using the bicycle ambulance in the MAM Scale programme have been for children in the category under 6. That's probably not surprising, because that's what our programme has had a large focus over the last 3 years. And we've recorded 3,681 transfers by bicycle ambulance to date, and that number's rising all the time. That's from the latest community monitoring system data. We've had very few confirmed COVID-19 referrals via the bicycle ambulance, but as my colleagues were explaining earlier, the emergency transport scheme riders treat every case as a possible COVID-19 case, applying all of the COVID-19 protocols. And I would say it's really thanks to the good efforts of the Ministry of Health, the district health management teams, and the programme team that has done a great job to actually keep COVID-19 at bay and put a really large focus in many of the rural districts that we're working in. Of course, that's something we have to not get complacent about and keep going. On the maternal aspect, that's a really important. Maternal transfers using the bicycle ambulance have absolutely kept going. We report on 17 indicators, and so we don't actually gather data in this programme about the number of referrals for pregnant women to get from communities to health facility. But as the programme, the MAMA's programme, brings that legacy, we know that those referrals are taking places, and they are ensuring that women, instead of delivering at home, or if there is a complication during pregnancy, they can get much quicker to the health facility. And we know that in a rural setup, those trips can be potentially life-saving. So thank you for that question and shining the spotlight on maternal cases as well. Thank you.
Great, thank you very much, Caroline. We have a question here from Chris Warren of PMI. Did we forecast the required RAS quantities based on the projected number of severe malaria cases, or based on the number of community health volunteers who are meant to have stock on hand on a continuous basis? And the answer to that is a bit of both. When the project first started, we were supplying the RAS. Now the procurement is happening at national level. So in the early stages of the project, basically we based it on a projection of the number of severe malaria cases, but we adjusted that figure based on health systems challenges. So yeah, we can share more information about that offline if you're interested. Okay, so next question. Yeah, there seems to be a clear positive impact from the intervention, and it seems to be a combination of the RAS and also the use of bicycle ambulances. So has any work been done to split out the contribution of each of those to look at them independently? Maybe I can ask that question of Paula.
Yeah, it's not an easy question to answer because you know, it's really difficult actually to separate different aspects of a comprehensive approach, and there are many elements of our approach that are contributing to the overall results. So I think in principle, no, we can't really split that answer, but we do collect data of, you know, how much the transport is used and the distances that are covered, etc. But I think it's a much more complicated kind of analysis that you'd need to do if you really wanted to split out. We also have, you know, these are distinct districts where we're working in with many different features across the different communities even. So really teasing out all these different elements is I think not really feasible, but I don't know if that's a sufficient answer, Kathy, or I mean, if the other team members want to add in more.
No, that's great. Thanks very much, then, Paula. So another question, and maybe I can ask Hans this one. Is there any sort of international guidance that incorporates the concept that allows for a rational amount of RAS to expire in the hands of a community health volunteer?
Yeah, this is indeed a little bit in the line of the question that was asked by Chris from PMI. It's a difficult one because countries will have different, let's say, distances to next level health facilities where comprehensive severe malaria case management can be provided. So I think the approach that has been chosen in the MAM Scale program to look at the individual communities, know how many, let's say, children under the age of 6 are there, and then what are the distances to their health facilities, and basically make a calculation on, you know, how many severe malaria patients would benefit from a pre-refer intervention, as opposed to patients who are very close to a higher level facility. And that's the way you should actually look at it. So it's very individual. Even within the countries, there will be major differences how to go about this. So it's difficult to say, you know, per community health worker, you would need X amount of artesunate rectal capsules.
Okay, thanks very much then, Hans. I think actually our time's up on the Q&A, but as we said before, we'll try to send some written responses to any other questions that come through. So thank you very much for your participation there. I'd like to hand over now to Dr. Given Chapa, who is the District Health Director of Serenji. She's going to do final comments, and then following that, we're extending a warm welcome to Dr. Mutindo Mudenda, who's the Acting Director of the National Malaria Elimination Centre in Zambia. So a very warm welcome both to Dr. Chapa and Dr. Mudenda from us all.
Thank you.
All right, thank you so much. I think most of the things have been mentioned by my colleagues, so I'll be brief. Yeah, so since 2017, the beginning, I think a total number of 3,831 children have been given RAS as pre-refer intervention. And most healthcare workers across the district have received training in an injectable artesunate. All the RAS-trained community health volunteers who have been oriented in COVID-19 response. The MAM Scale approach is appropriate and is evidence-based, as Dennis highlighted. It combines case management training for community health volunteers with training in community engagement and mobilization. So the food banks and savings scheme established at community level have helped to reduce some of the financial and other practical delays to prevent families from responding to severe malaria danger signs. Serenji is one of the 4 districts with an emergency transport system based on bicycle ambulances, and it's being used and it's been integrated not only for malaria but also for maternal cases. We believe this system is helping to reduce the referral times. So these innovations have increased access to RAS at community level, through provision of the emergency transport and establishment of community systems like food and schemes. So the pilot project resulted in a 96% reduction in case fatality rate. I can attest that from the beginning of this year, we've only had 1 malaria death in the district. As the national scale-up of RAS continues and based on our experience in Serenge, I would recommend that community health workers who are trained in RAS receiving training in both case management and community mobilization. This strong community component has really helped to reduce malaria mortality. It has also helped to improve community health volunteers, community mobilization skills more generally. The MOH has worked towards ensuring a continuous and reliable supply of injectable artesunate and other antimalarials. I think from the data presented by Dennis, I saw an 80% availability, but I can assure you that I think we are now at 100% in terms of quinine, coartem in most of the facilities that we have. Zambia invests in emergency referral transport since this helps to save many lives. Community managed transport options have been appropriate and have sustained the district. More district and provincial ICCM trainers are trained in RAS so that the MOH has enough capacity to support the national scale-up. I think next week we'll be having about 500 community health workers being trained in ICCM in the district. And from what Hans has said, I heard that the RAS component has been included in the ICCM training. However, I'm not very sure if this one has been funded appropriately. I think I would love to have more from Hans. So health workers from newly opened facilities in Serenge have been oriented in RAS and community mobilization. However, I think as a district, we have about 6 or more facilities that will be opened up soon. So I'd love to hear if there are any plans that maybe our partners can intervene in terms of support for these newly opened health facilities so that they can also have full training in RAS administration and artesunate injections. Thank you so much. I hand over to Dr. Mtinta Mdeni.
Thank you, Doc. Good afternoon to everyone on the call. From my end at the national level, just to say thank you for the collaboration that we have enjoyed. Indeed, it was in the 2014 treatment guidelines that we initially said we want to be using injectable rectal artesunate for pre-referral, but it was only when mamas came on the scene that we did the pilot, and that went very well, as has already been highlighted by people who have spoken before me. So at the national level, it is something that we are happy with, and though we have not been able to expand it at a rate that would be happy with, as at present we are in 10 districts, but that's not enough considering that we have about, more than 100 districts in our country. We have about 116. It's a step in the right direction in that we have made the increment in terms of those that are administering it, but commodity availability has been the limiting factor. In terms of training, we have trained an additional almost 7,000 or more that have got the knowledge of how to use the rectal artesunate, but we're yet to deploy it to them. We are hopeful that maybe by the end of the year, our stock status may be better than it was in the previous year, but the gap still remains. We still at national level have to train about 10,000 additional community health workers in the same. So it is something which I'd say that we have made headway. We have trained a number, but we have not yet reached the limit, the desired numbers that we have. And for those that we have trained, we have not yet reached the levels of implementation that we wish to reach because of availability of the drug. We hope that we improve, but we certainly have got room for more partnerships, if there are people that you're able to join in the fight, because it's certainly a worthwhile cause. It's a worthwhile cause when you can have severe malaria deaths reducing remarkably, then it is something worth doing and doing more and more of. So we say thank you to the partnership that we have had, and we look forward to continued collaboration and even expanding not only your geographical areas of collaboration, but maybe even in terms of, we look forward to a time maybe where you could also, if at all possible, find some donors who could help maybe with the commodity or with the transport system, whichever. So in short, thank you, and we look forward to working with you continually. Thank you.
Thank you. So I think I am supposed to close now. So we're already past the hour. So thank you to everybody for staying on even a little bit longer than the hour. I think, you know, just seeing so many people on the panel and also all the visitors shows what an interest there is in malaria and community level work. And what a fantastic partnership this has been. This has been underway now for over 10 years, many of us working together, working at community level in Zambia. It's been a fantastic partnership with the government of Zambia, both at the national level and at district levels. In all the districts where we're working, there's really enormous collaboration and buy-in from our government partners. We look forward to continuing this work, and as Dr. Mudenda and Dr. Chaba have asked, to extend it even more. So we invite everybody to look for new donors and partners to help us continue and expand this work. If you need more information, there is plenty of resources available on both the TransAid websites, on DAI websites, and MMV websites, and hopefully also on Zambia government website. But we have a lot of resources. We have reports and evidence briefs showing exactly how the approach works, what the results have been, and all the lessons learned. So please do browse through those and feel free to get in touch with us for any more information. We'll hopefully send some of those links out with this recording. So I'd like to thank everybody for, again, a fantastic partnership, wonderful experiences from Zambia, and thanks to all our hardworking team who have made this all happen. Thank you.
Thank you.
Thank you.